The purpose of the cardiac scan is to check for vital signs and to evaluate for volume or cardiovascular compromise and listen to the heart for accurate assessment of rhythm, a rub, and any new or significant murmurs. The physical exam is not very sensitive when evaluating for coronary artery disease. Check the pulse for rate per minute and regularity. When checking for a complaint of dizziness, fainting, palpitations, or suspected rhythm disturbance, the pulse should be palpated for at least 30 seconds. 50 to 80 beats per minute and regular without any pauses is normal at rest. Less than 40 is bradycardia and greater than 90 is tachycardia at rest. These heart rates may be quite transient, but if they persist may lead to a significant compromise depending upon the patient's age and cardiac status. Also note if there are any pauses. Pauses greater than 2 seconds can be serious, especially if the patient has fainted or has a heart rate of less than 40. Determine the cardiac rhythm at a peripheral pulse site unless it's difficult to feel. If it's difficult to feel, move to a more proximal pulse site or listen to the heart with a stethoscope. Next, we check the blood pressure. This is done with the patient sitting with the legs dangling. In a patient who complains of dizziness, feeling as if they will faint or have just fainted, you should take the pulse and blood pressure in a supine position and then take it again in a sitting position with the legs dangling and standing if they're not orthostatic in the sitting position. If there's a positional pulse increase of 20 or more beats per minute, or a drop of greater than 20 points of diastolic or systolic pressure, then the patient may be orthostatic. If the blood pressure is in the hypertensive range and the patient's experiencing a tearing or diffuse and migrating midline thoracic pain, this may be evidence of a thoracic aortic dissection. If the blood pressure is low, systolic less than 85, or 20 points less than the patient's normal blood pressure, and the pulse is high, this may be a set of vital signs in a patient with severe cardiac compromise. Blood pressure changes associated with activity typically reflect the amount of work the heart must do to meet the metabolic demands of the activity. Accuracy in measurement is critical to the correct interpretation of the blood pressure. Problems arise in the accurate measurement of blood pressure with activity when the therapist is not using good technique. When a patient stops performing an activity, the direct metabolic demands decrease, while the muscle activity that assists in the return of the venous blood stops. As a result, blood pressure may drop rapidly. Therefore, it's essential that the physical therapist be competent in blood pressure measurement and knowledgeable regarding the normal blood pressure responses to exertion, in addition to being able to identify and react to abnormal responses. Listen for heart sounds with the bell of the stethoscope. The aortic area is best auscultated in the second intercostal space close to the sternum on the right of the sternum. The pulmonic area is auscultated best at the second intercostal space to the left of the sternum. The tricuspid area, located at the lower left sternal border, approximately the fourth to fifth intercostal space, and the mitral area, or at the apex of the heart, located in the fifth left intercostal space, medial to the midclavicular line. This can be done in both sitting and supine positions. A rub may be a sign of pericarditis, especially if the patient has a fever and tachycardia and an atypical chest pain which is relieved by leaning forward. The therapist is mainly screening for serious compromise in vital signs or signs that may link the cardiac system with the atypical chest or referred pain. The pulmonary scanning exam. Inspect the patient's breathing and look for nasal flaring with inspiration, pursed lip breathing, bluish skin color, and the use of accessory muscles of respiration, such as the sternocleidomastoid, upper traps, and intercostal retraction. Take the vital signs including the pulse, respiratory rate, and blood pressure. The respiratory rate per minute should be taken for at least 30 seconds to be accurate. It can be done by observing and counting the inspiratory phase of the thoracic wall anteriorly, or by listening with a stethoscope over the trachea or anywhere that breath sounds can be clearly heard. Greater than 16 breaths per minute is abnormal in a patient at rest and should raise the therapist's suspicion of either pulmonary disease or a compensatory increase in respiratory rate secondary to fever, cardiac pathology, or pain. Listen to the breath sounds with the diaphragm or the flat part of the stethoscope. The therapist in an outpatient setting is primarily listening for a significant reduction in breath sound amplitude and the lung apices in the upper lobes to indicate a possible pneumothorax as a cause for atypical neck, shoulder, axillary, and proximal arm pain. Therapists that work in an inpatient or respiratory unit will need to learn a much more thorough chest exam. To listen to the lung sounds, place the diaphragm in the supraclavicular area in the midline and in the superior trapezius on the side with the pain, and ask the patient to take a deep breath and compare breath sound amplitude to the opposite chest and ask the patient if there's any pain. Also listen on the posterior chest wall between T5 and T3 spinous processes, just medial to the scapula. If the breath sounds are difficult to hear, ask the patient to abduct the shoulder girdle greater than 90 degrees to move the scapula into an upward rotation and make breath sounds slightly more audible. Anteriorly, listen below the clavicle and above the fourth rib to listen to the anterior segment of the superior lobe to finish the screen for a pneumothorax, with the findings of markedly decreased breath sounds unilaterally and often an increased respiratory rate. If one finds unusual breath sounds in these or other areas, with crackles, rubs, tracheal or brachial breath sounds, one should ask the patient to seek further medical referral. One may also listen to these areas for signs of asthma in a patient with a history of asthma who appears to be short of breath or using accessory muscles of respiration or coughing excessively after exercise. In a patient with known or suspected severe asthma, a peak flow reading should be considered with a plastic peak flow meter. A table of normal values should be kept in the therapy clinic, and the patient with asthma should write down on the original history sheet their normal peak flow reading in liters per minute. In general, any peak flow reading of less than 250 should be immediately referred to a medical facility. Patients with less than 80% of predicted should be asked to contact their healthcare provider promptly. An oral and lateral anterior neck scanning exam should be done in the patient who presents with atypical anterior or lateral neck pain. The therapist is basically trying to rule out an oral infectious cause, tooth or neck cyst, lymph node, or inflamed thyroid cause of the pain. Perform an oral exam by inspecting the teeth and gums with a light, and then have the patient bite on a tongue depressor and evaluate for local or referred pain. Focus special attention on the root canal or damaged teeth. Look for areas of swelling in the floor of the mouth. Look for tongue and posterior throat swelling as a sign of infection or angioedema. Significant swelling anywhere in the oral cavity, especially if there's fever and or respiratory or swallowing compromise, is a cause for immediate medical referral. Inspect the neck for areas of swelling or visible lesions such as cysts, skin lesions, lymph nodes, or enlarged thyroid gland, and palpate the lymph nodes in the preauricular, posterior, and anterior cervical chains. The thyroid gland lateral lobes extend from the side of the thyroid cartilage to the proximal tracheal rings. It's not usually visible, tender, nor palpable, but if it is, it may be indicative of a goiter, nodule, or an inflammatory condition and a cause of anterior neck pain. Palpate the thyroid area just inferior and lateral to the laryngeal prominence of the thyroid cartilage and superior to the sternal notch and medial to the sternal origin of the sternocleidomastoid. Use the index and middle fingers of both hands, and palpation is facilitated by asking the patient to take a drink of water while the therapist's fingers are in position. Examination of the lateral neck for carotid artery bruits. The carotid artery auscultation is initiated with the patient either supine or sitting. In the latter position, approaching the patient from behind allows optimal simultaneous carotid palpation and auscultation. The patient's chin points straight ahead, and the stethoscope bell is applied to achieve a skin seal over the course of each carotid artery. Simultaneous with auscultation, the examiner's free hand lightly rests on the contralateral carotid artery for timing purposes. Then the patient is asked to inspire deeply and hold their breath without Valsalva for 15 to 30 seconds. Auscultation continues during and immediately after breath holding. Holding the breath not only eliminates breath sounds that make hearing a bruit difficult, but also accentuates an internal carotid bruit. With the patient holding his breath, the examiner next compresses the contralateral common carotid artery slightly to determine whether this alters the length or intensity of a bruit. Remember that transient focal cerebral ischemia has been reported from digital pressure on neck carotid arteries, so diagnostic carotid palpation is probably contraindication in a patient with pre-existent brain ischemia. Finally, the examiner combines patient breath holding with simultaneous compression of both the ipsilateral superficial temporal and facial arteries. This last maneuver may be accomplished from behind or while facing the patient.